Hi everyone, my name's Bruno Silva. I'm one of the dentists here at Brighton Implant Clinic, and today I'm going to be talking to you about the main differences between acrylic and zirconia, the materials that are commonly discussed with the dentists and patients in terms of what that material choice is going to be when looking to have your definitive or long-term fixed teeth. So I work at the Brighton Implant Clinic, and I've been privileged over the years to help many patients through this process, and I've seen some major improvements over that time, and I would like to share those experiences and those opinions with you on this short video. So my journey with All-on-4 type solution started in 2005, and at the time we here at the practice were providing mainly acrylic bridges, and that material was basically used for both the provisional and the definitive bridge. And there were many reasons why that material was actually the material of choice. It worked really well, and we had many patients that had these solutions and were very pleased and are still very pleased with them. So the provisional bridge, which is the bridge that is firstly made after surgery, normally this is fitted on the same day or the day after surgery. We make this in acrylic so that it's quite a quick turnaround for the patient. So we want the patients to be without the teeth for as little time as possible. So usually the patients will have surgery, for example, in the morning, and we would fit teeth in the same day in the afternoon or the next day. And with only really acrylic can you actually make this possible in a short space of time. During that time, they will have this acrylic bridge for up to 2 months. And during that time, we're waiting for the implants to heal, to embed within the bone, and to check within that 2 months that they actually are going to be successful. After 2 months, patients will come back and see us, and then we'll start talking about what are the features that they would like to improve when making the final bridge, and what are the effects that they would like to change and improve or alter before the definitive teeth are made. So in the past, the definitive bridge was made in acrylic as well, and this whole process was done in what we would call an analog, or basically like made by hand process. The teeth were set by hand, they were cured and adjusted by hand, and the results were amazing. They worked really well, and patients were generally very happy with the results. However, there was a small number of patients whereby acrylic became a material that wasn't strong enough, and with those patients they tended to break the material, tended to break their teeth very commonly. And even if this was a very small number of patients, it still had a big impact on obviously those patients where if it happened to them, it would be like a major problem, because a tooth would break off and it would always be at the kind of the worst possible time, either on a weekend or they were away. So even if it was a small number of patients, those problems over time started to become more apparent, that we really needed a material that was more robust and stronger. So sorry, I've digressed a little bit. I'm talking that it's not very common that patients were breaking the temporary bridges. Those are the ones that were basically made during the time of the healing time, because our instructions at that stage were also like, you need to keep to soft foods, try not to eat things that are very hard. So patients were being a little bit more cautious at that moment in time. But when patients came to see us and we were making their definitive bridge in this analog workflow, and once the treatment was finished, we were telling patients, look, these teeth, treat them as normal. You can eat harder foods. Obviously don't eat things that are, that would be kind of dangerous for natural teeth. Be careful, don't eat very hard foods with these, because they can break. We were seeing that patients were coming back and they were finding that teeth were occasionally breaking or bridges were breaking. So over that period of time, we started to explore different options, and we started to see that the industry was starting to introduce different materials, and zirconia became a material that was a lot more spoken about. And at the time, 2014, 2015, when we started using zirconia for full arch bridges, we began to see that the material was certainly much stronger. The process of how the the bridges were made was quite involved. It involved several stages of treatment. It meant that we needed to necessarily take the same amount of precautions that we did with acrylic, but we had to be that much more precise, because zirconia as a material, it's much harder, it's inflexible, it's unforgiving, and it needed to be really, really precise. Otherwise, we had a whole list of other different problems that we didn't have with acrylic. So acrylic's a little bit softer. It can flex slightly. It can accommodate certain imprecisions that the dentist or the patient might not even be aware of. And the main problem with acrylic was that over time it tended to wear down. It tended to wear down much faster than zirconia, for example. It became stained, and it also tended to attract more plaque, so it was more difficult to keep clean. The problem that we had with zirconia was that at first the zirconias that were available, manufacturers were saying, look, this material is fantastically strong, it's much more durable, it's almost unbreakable, it's about 10 times stronger than acrylic. The problem that we had with zirconia at that stage was that it didn't look very aesthetic. It was a very dense white material, and it was quite difficult to use this as an alternative to acrylic. The acrylic bridges, on the other hand, apart from the disadvantage of being weak and staining easily and sometimes breaking, they looked fantastic. They really looked very natural. The pink gum artificial tissue looked really good, and patients really found them to be like really aesthetic. So zirconia was there in terms of strength, but we didn't have the aesthetic result that we needed to with zirconia. So what we were doing at that stage was that we would use zirconia as a main structure, and we would actually use porcelain and actually mask the zirconia with porcelain on the front teeth. So that would mean that we'd have to trim back about 1 millimeter from the front of the bridge, and we'd have to basically bake on porcelain. And this made the bridge look much more realistic. It looked much more aesthetic for patients. So we had a solution there. The disadvantage of doing that, and we call this in dentistry like a cutback technique, the disadvantage that we had with that solution was that porcelain on implants, on zirconia or on metal, has a tendency to chip, because you bake porcelain onto zirconia, and when you have some impacts on it, especially if you have opposing crowns, it tended to cause problems with the porcelain that was stuck to zirconia. So we had bridges that were now looking more aesthetic. They were stronger, they were more durable than acrylic, but sometimes, again, not very often, but maybe 1 in 30, 1 in 40 patients would come back and say, the porcelain on my front tooth has chipped away, and there's nothing you can do about it. You can't repair it. It can't be, nothing can be added. The whole bridge needs to be made again, simply because a small area of porcelain would chip away from that zirconia structure. So we were really kind of stuck, really not knowing how we could improve this solution. And thankfully, as time went on, the zirconia materials became more advanced, they became more aesthetic, and the trade-off that we found with those materials were, as zirconias became more aesthetic, their strength actually was reduced slightly, because the material became more translucent, and it then became possible to actually make the entire bridge out of zirconia. So no longer did we need to put porcelain onto the zirconia to mask the super white structure that we had behind the porcelain. We could now actually make the entire bridge out of zirconia. So this was now opening up a real possibility of moving away from acrylic completely, and actually to zirconia bridges. Again, we had some issues with this in that the zirconia itself, because it had reduced in strength, we had some areas where patients were quite happy to have a zirconia bridge, and there's a slightly higher cost for a zirconia bridge, but we were then seeing that we had some breakages with zirconia, that the material itself, because it had become weaker to make it more aesthetic, that it was now still not an ideal solution for us. So fast forward again some more months and years, And I believe we've now got to a situation, and this is now probably for about 2.5 years, whereby we have still, a beautiful zirconia bridge. So the material is still only zirconia, so there's no porcelain. So we've basically haven't had any issues with porcelain breaking off zirconia. So it's just a zirconia bridge. And we now have a titanium frame, which is actually embedded within the zirconia bridge. So this is actually made in a separate production process. And this frame basically is embedded within the bridge. Now, we've able to given us what I believe is probably almost an ideal, perfect solution with the materials and processes that are within our realm. The titanium frame inside the bridge is now, it's more resilient. It's a little bit more flexible than the zirconia on its own. So it is very precise. So this is made in a digital workflow, and we capture the information to make these frames without impressions. We actually use a specific scanner that actually captures the positions of implants. And with that information, we design a frame that will support the zirconia. So it's almost impossible for the zirconia bridge to break, because it's, again, almost impossible to break this titanium frame. It's custom milled for each patient. The zirconia that's then made is like a shell, which is supported by this titanium frame, and we don't need a porcelain. So it's very aesthetic, and given that the zirconia's strength is slightly lower, it means that we've got these two materials working together to actually give you a very, very durable, very strong solution. So to summarize, we now have bridges that are zirconia and titanium. They are resistant to staining. They are resistant to plaque adhering to it. We still see on yearly reviews when patients come back that in some cases, and a very small number of cases, you may find some plaque adhering to the zirconia surface, but it is far less than when we had all of our patients using acrylic bridges, and that's more commonly on the lower bridge. And the material, it's more hygienic, it doesn't smell, it doesn't stain, and it really looks very, very aesthetic. It looks like natural teeth. It looks like natural enamel on that you would see with natural dentition. So to summarize, this process is actually done here in the practice, and all of our dentists are trained and equipped to be able to provide this treatment solution. What I particularly like about the digital workflow that we're using at the moment, first of all, for patients, there's no impressions. So it means that we can capture this information by means of scanners and by means of digital impressions that we normally needed to use conventional impressions for. But the really great outcome from this is that once we've got a part that has been designed, a bridge, a smile that's basically been designed and our patients are happy with, we basically save that design. It gets stored with the patient's file in the cloud, and we're now able to replicate or reproduce that design in a year's time, in 5 years' time. If there were ever a problem, if the bridge were to break, we no longer need to go to our analog type workflow where we would need to start from the beginning, take impressions again, make models again for patients. All of this information is stored in the patient's file. We can then take that part design, we can put it on one of our 3D printing machines or our milling units, and this can then manufacture a new bridge for the patient exactly the same as when the original bridge was made. So that's a digital workflow, and it's really making a massive improvement on how we are able to deliver a more predictable, a more precise, a more accurate, and just an overall superior result for these types of solutions. So I myself, I work here at the clinic. I've been focusing mainly on patients that need a full upper or full lower arch of missing teeth for a few years now. And I'm really delighted with the results that are being produced. I'm proud of our team that we have here. We're constantly pushing ourselves to deliver something that is even of a superior quality and of a higher grade for our patients. So a bit technical, and I hope I didn't lose any of you along the way. But yeah, if you do have any questions, if you have any doubts that you'd like to know a little bit more about this treatment process, I'd be delighted to help you. You could send us a message on our email address, info@brchove.co.uk, or you can call us. Our phone number's in our contact details. Our website is www.brightonimplantclinic.co.uk, and yeah, hope to see you again soon, and thank you so much for this long video. All right, thank you, cheers, and bye-bye.